You got it.
Got it. Okay. Hi, everyone. Thanks for joining us. I'm really excited because Jamie is a wealth of information and knowledge and also one of my dear friends. So thanks for joining us. And I'm going to embarrass her and read her whole bio. Um,
Thank you.
Jamie Singletary is a licensed and nationally certified professional counselor with a passion for helping individuals navigate life's challenges and achieve mental wellness. With a unique background that includes 6 years as a former NFL cheerleader, Jamie combines her experience in performance, discipline, and teamwork with her experience in mental health to offer well-rounded, empathetic approach to therapy. After graduating from Ball State University in 2001 with a BA in corporate communications and Clark Atlanta University in 2005 with an MA in clinical psychology, Jamie pursued her passion for mental health by specializing in areas such as anxiety, substance use, self-esteem, body image issues, stress management, and eating disorders. Her personal experience with the pressures of high-level performance and public visibility has shaped her ability to connect deeply with individuals facing similar struggles, including athletes, performers, and others in demanding professions. As the Director of Clinical Brand Development and Alumni Programming for Within Health, she is dedicated to providing a safe, supportive space for clients to explore their emotions, build resilience, and foster positive growth. There you go, Jamie. All right. And I will hand it over to you. Before I let you get started, if you have any questions, I would say anyone can just send them directly to me in chat, and then I will ask Jamie as we go along. Okay, up to you.
Thank you. Thank you, Tammy. Thank you, Southwest Philly IADEP. That is a mouthful
It
for
is. You could
having
even
me.
hear I say it all the time, and I still messed up
Yes.
saying it when I was doing my intro. You're good.
My goodness. Thank you. Thank you. Thank you so much. It is my pleasure to be here. I am happy to talk about this topic. As Tammy mentioned, she and I have been friends for some time now, and we were just kind of talking about bios. And I said, it's so weird when you're standing there and the person's reading your bio, and it's like, she's done this, she's done that, she does this. And I'm thinking, oh my gosh, have I done that? But this time, the takeaway were the years that you mentioned that I graduated from school. And I think I may take those out just because reminding myself that I graduated from undergrad in 2001 and grad school in 2005. Yeah, that's thanks, Tammy, for reminding that. No, I'm kidding. I
Oh,
am
yeah.
I'm happy to be here. And as Tammy mentioned, with questions and any kind of comments, I love that. I love it to be interactive. I know that sometimes when we're doing these talks, we can just kind of fly through the information. But this one is something that is very near and dear to me. As Tammy mentioned, I am currently the director of brand development for Within Health. And, what does that mean? That means that my role is to make sure that our brand is visible and that is it accessible, and that when people see those purple hearts intertwined, that they know that Within Health is in the building. And so having a role like that and working with our alumni and being one of our BIPoC providers, it really has given me the opportunity to inform, to make care accessible, and to step into environments where you don't really hear a lot about eating disorders. And just to give a little background on my bio, as Tammy mentioned, I was a NFL cheerleader for 6 consecutive seasons between two different teams. And when people think of NFL cheerleaders, a lot of things come to mind. We don't have to list what comes to mind, but there are a lot of things that come to mind. And one of the things that kind of sticks out in the forefront is image, body image. And we'll get into that in a little bit. But I did my undergraduate work in Indiana, where I was born and raised in Indianapolis, Indiana. I went to Ball State University, which is considered a PWI. And if for those of you that aren't sure what PWI means, it's a predominantly white institution. And then I did my graduate work here in Atlanta at Clark Atlanta University, which is considered an HBCU. And if you don't know what an HBCU is, it's a historically Black college or university. And the reason it's important for me to mention that is because it really plays a part in this conversation. Who knew although several years ago, that these two institutions, who I hold near and dear to my heart, would shape and form conversations that are very apparent in our field of work. So, without further ado, let's go ahead and get right into it. So today, our objectives, right? We have four that I want to cover. The first one is we're going to understand how historical and systemic inequities affect access to care and treatment, outcomes for BIPoC individuals with eating disorders. We're going to learn how to identify and address implicit biases that may influence clinical decision making and interactions with BIPoC clients, and explore a variety of communication styles that can be used for building trust, validating experiences, and engaging in open, non-judgmental dialogue with BIPoC clients. And lastly, learn how to create individualized, culturally responsive treatment plans that respect clients' food traditions, family dynamics, and lived experiences. So when we think about that, I know that probably everyone on the call is familiar with eating disorders and can whip out a treatment plan and can make an assessment and can get on a call with a colleague and do some, case conceptualization and provide feedback and provide, different ways that we can treat our clients. But when we throw in an extra layer of a cultural lens, I wonder how many of us are comfortable, how many of us have had an opportunity to get formal training to understand what that may look like and how that shows up with our clients that are presenting with eating disorders. I know for me, I've been in the eating disorder space for almost 9 years now, and there is still a huge gap between what eating disorders are, who has eating disorders, how we treat eating disorders, and what that looks like from a cultural BIPoC community lens. Why does subject matter like this even matter? Well, a few reasons. It's important because there's underdiagnosis and there are misconceptions. And it's important for us to take a look at why these underdiagnoses and misconceptions exist. It says here, historically, eating disorders have been wrongly stereotyped as illnesses that primarily affect white affluent females. This misconception contributes to the underdiagnosis and misidentification of eating disorders in Black, Indigenous, people of color, the BIPoC communities. There are so many acronyms and long words in this presentation. I apologize in advance. But when we talk about BIPoC, that is what BIPoC means. And I think it's important to even just recognize that the term BIPoC is something that is fairly new in our field. When I was in school, we did not have terms like BIPoC. We were not having these conversations. And so I think it shows that the field is growing, the field is changing, the field is recognizing that there is a gap there with a demographic of people that are suffering from eating disorder. So when we reference BIPoC, we're referencing Black, Indigenous people of color. The research shows that individuals with the same or more severe symptoms are less likely to be diagnosed with eating disorders compared to their white counterparts. Why is that? And I think the answer is simple, right? Because they're not being asked. As Tammy mentioned, the reason that I wanted to put in my bio that I was an NFL cheerleader is because I was an athlete. I've been an athlete most of my life. I started running formally at the age of 9 with AAU, traveling, competing against other children in my age group. So I've had a multitude of doctor's appointments. I've had physicals. I've had this. I've sprained ankles. I've done all these things. And from an adolescent up to an adult, I have never had a provider ask me anything about eating disorders. Now, would they ask me, did I have an appetite? Of course, they check a box and they would go to the next question. But when I would have these very same conversations with my teammates or just other colleagues, they would say that their questions would look a little bit different. So why are we not being asked? Is it because of these misconceptions of what eating disorders look like? Is there a stereotype that people of color, males, whoever, don't have eating disorders? That's not the case. We're just not doing the screening. Being in a profession at that time when I was a cheerleader, it was all about body image. The entire time that I was on those teams, there was never any education around nutrition. It was just, you need to make weight. You need to be able to maintain the weight that you are when you made this team. Nothing going into, well, how did we get to the weight that we are now? How do we maintain this? What do we need to do? What are the do's? What are the don'ts? It was just look good. Just make sure you look good in the uniform. Looking at some more of the statistics, 20 to 26% of individuals with an eating disorder are BIPoC, 50% lower likelihood of being diagnosed or receiving treatment is found in BIPoC individuals with an eating disorder. There's a 50% greater likelihood of exhibiting bulimic behaviors such as binging and purging is found in Black adolescents compared to white teens, and 2.5 to 4 times higher lifetime prevalence of bulimia nervosa is found in Black and Latino populations compared to non-Latino white individuals. These statistics were pulled from our director of research at Within Health, Dr. Caitlin Shepard. And if you visit our website, you will see that we have some of these statistics and other information specifically about BIPoC population on our website. But it just goes to show that the people are out there. The issues are presenting in these communities. And where are they going? Where are our BIPoC clients and friends and families? Where are they going to get care? Where do they feel like they can go and get care and be represented? Diagnostic bias, right? So, as I mentioned, when I was in school, I don't know about you all, but there was no special carve out for eating disorders. It was some substance use, there was some family, there was some school counseling, there was relationship, but there wasn't anything about eating disorders. I don't even think anyone in our program had an opportunity to do an eating disorder internship. I did my internship when I was in grad school in a substance use facility. So it just goes to show that we're playing catch up when it comes to the eating disorder field. I don't know where you all were first introduced to the eating disorder field and what that curriculum looked like, but for me, it was really on the job training. I had the opportunity to work in a psychiatric hospital, and one of the programs that that hospital offered was an eating disorder program. And when I was working in that hospital, I was working as an outreach person, so I wasn't as clinical and client facing as some of my other peers were, but I was in the space. And when I was going to market that program and working with the colleagues and clinicians that were treating eating disorders, I began to see then that I was the only person at some of these conferences that looked like me. It was a huge discrepancy in terms of just visibility, which I was thinking, this is interesting because when I go to general psych conferences or I go learn about any other mental health disparity, it seems to be more diverse in the room. But with eating disorders, it is very apparent that it lacks the inclusivity and diversity from clients as well as providers sometimes. Diagnostic bias refers to systemic errors or assumptions that affect how clinicians identify and label mental health conditions, often influenced by stereotypes, lack of cultural competence, or unexamined personal beliefs in the context of eating disorder. And this can lead to a few things. When I mentioned that I went to a PWI and I attended an HBCU, the reason that's important is because at my PWI, there was no cultural reference to anything unless that was what you were majoring in. Sure, there were things on campus that were designed for minorities to participate in, whether that be Black Greek letter organizations, whether that be certain clubs or affiliate government, student association boards, but an overall there was not anything specific that looked at things through a cultural lens. Transitioning from the Midwest, one particular area of the country, coming down to the South, where the culture is a little more rich in terms, and attending an HBCU, culture was in the forefront. It was prioritized. Everything that we learned about our selves was also incorporated into the psychological world because there was an immediate just announcement that a lot of the things that we're learning from a psychological standpoint were not designed to include other demographics. If you go back to grad school and you think about your theories of counseling and you think about who the theorists are and you think about who the founding fathers are of psychology, it is very limited to one viewpoint, white males. And we don't hear a lot about research incorporating other family dynamics. It's a very, kind of just one-sided view into our field. And so being at an HBCU, it provided an opportunity to look at things through a cultural lens while also learning mainstream. So looking at some of the things that the diagnostic bias leads to, we said delayed intervention resulting in more severe symptoms by the time treatment is initiated, inadequate treatment plans that don't address the patient's full experience, distrust in the healthcare system, making it difficult to seek help. And what do we mean by distrust in the healthcare system? It's one thing to say, I just don't like to go to the doctor, or the doctor is a quack, or they're not going to get it. But it's another thing from a clinician standpoint to understand why some of our BIPoC clients might have distrust in the healthcare system. When we live in a country where we have been subject to seeing certain things like the Tuskegee experiment. And if you're not familiar with the Tuskegee experiment, I would familiarize yourself with that. When we hear stories like Henrietta Sacks, where there have been times where people of color have trusted our healthcare system to do things for our betterment. However, there was misleading information there. There were things that ended up being more hurtful and harmful than helpful. And we sometimes don't know how these messages have matriculated through generations to some of our clients who are coming from these communities. If I know something that has hurt me, my knee-jerk reaction would be to tell my son, hey, you don't want to engage in that because that's been harmful to me. So it's not that there is not a recognition of I need help, but there is just a where can I go? Where can I go and where can I feel safe? And I think it's important to understand that when we're thinking about our clients that are coming from some of these communities. These biases are not always intentional. It's important that we mention that. These are not always things that are happening because somebody is intentionally wanting to hurt. They just often stem from gaps in training, institutional racism, and the historical development of diagnostic criteria primarily centered around white populations. And I think when we're doing talks like this, it provides an opportunity for us to just get a different perspective and to have some understanding and to learn, because we don't know what we don't know. And I think if we're leaning towards being helpful, that these are some of the conversations that we as clinicians and professionals need to open ourselves up to, just so that we can be familiar. And Tammy, please stop if something pops up in the chat that we want to spend a little more time on, okay?
Of course.
Thank you. All right, so looking at history, right? I have known for a while that eating disorders exist, right? But I had never really looked and took the time to look at how eating disorders exist from a historical standpoint. And the more that I attend conferences, I do feel like in some of the talks that we are becoming more aware, and we are really putting forth an excellent effort to eradicate a lot of the stereotypes and a lot of the stigmas that go along with the history of eating disorders and how that plays out in our country today. So when we think about this, it says here that the historical impact of colonialism and the devaluation of Indigenous and Black bodies. It's important to mention this because this is where we get a lot of our beauty standards. It says European beauty standards were imposed through colonialism, labeling non-European features as primitive or undesirable. So here we are again. If you don't fit into this one particular box, then you're not desirable. You're primitive. It's not good, right? So Indigenous cultures on the other end of the spectrum often celebrated larger bodies as symbols of wealth, fertility, and power. Colonizers condemned these body types, instead promoting thinness as a sign of civility and control. And when you think about the clients that you may see in your practice or in your programs, a lot of times we associate the eating disorder with a sense of feeling in control. Black women's bodies in particular were hypersexualized and dehumanized during slavery. And we're going to mention somebody in just a second, Sarah Bartman. I don't know if you're familiar with that. But This contributed to enduring stereotypes that portray Black women and other people of color as excessively curvy, outspoken, or otherwise defiant from Eurocentric standards. Okay, so we're looking at this divide, and these are things that started hundreds of years ago. And the reason Sarah Bartman is important is because Sarah Bartman is a woman that I learned about in graduate school. And I'm really grateful for hearing her story because this happened so long ago, a lot of the dates may not be exact. So I do encourage you to read about Sarah Bartman if you have an opportunity. But this is a picture of Sarah that was depicted from back then that they say how she looked. And she was born around 1789 in the Eastern Cape of South Africa. She was a member of the Khoi tribe, which is one of the indigenous peoples of Southern Africa. She was taken to Europe. In 1810, Bartman was taken to England under false pretenses. She was promised wealth and fame, but was instead exhibited in freak shows due to her large buttocks and physical trait that Europeans at the time exotified and misunderstood. So here we have a woman of color who has full features, hips, large buttocks, wider nose, fuller lips. And because this was different, this was dehumanized. She was under the impression that she was going to go into a space where she would make money, she would be celebrated, but instead she was put on display and humiliated. It says here in England, she was put on display in sideshows under the name Hottentot Venus, which is a derogatory term that the colonizers gave the Khoi people. She was taken to Paris in 1814, where she was similarly exhibited and later studied by scientists, including anatomist George, it's French, Cuvier, who made racially biased conclusions about African people using her body as a specimen. Bartman died in 1815, they say at about the age of 26. And the reason I think it's important to mention Sarah is because there are so many of our clients that I think have a little bit of Sarah in them, where they have been abused, where they have been tricked, where they have trauma, where they have, been told you don't fit in here, you don't have the look. And how do we work with the Sarahs that come across our caseload? So I just think it's very important. And when we look at the dates, we're talking about 1789, we're talking about 1810, and how much of that is still happening in 2025. So I just thought it was important to mention her because she represents, I think, so many of us, whether you're a woman of color, a man, or whatever. I don't think it matters. I just think that there's a little bit of Sarah Bartman in all of us, and I think we know a Sarah somewhere, and we can empathize and can relate to her story. Representation, imbalance, and its impact. Basically, what does that mean? It means that representation matters. And when there is a lack of representation, there is a missed opportunity. The issue of imbalanced representation in eating disorder treatment for BIPoC communities is a serious multifaceted concern. It can lead to insecurities, inadequate care, and worsened health outcomes. I want to talk about the doll test. I don't know who's familiar with the doll test, but if you can put in the chat, Tammy, if you can tell me if people are familiar with the doll test. Yes, no.
Yes. Yes. Couple yeses.
Okay. Couple yeses. Is anybody not familiar with the doll test?
There is a no.
Okay. So the doll test is a landmark psychological experiment that reveals the internalized racism and identity struggles faced by Black children due to systemic discrimination. It's highly relevant when discussing imbalanced representation and its psychological consequences, especially in BIPoC communities dealing with eating disorder. Here's an overview of the test and its implications. And again, this is just my assessment of how these things impact eating disorders. By no means is everything that I'm saying the gospel. Please, do your own research, but this is the interpretation to me and how I have seen it play out in the eating disorder field. So this is a married couple. Can you imagine the conversations that they would have, two married psychologists at the dinner table? But Dr. Kenneth Clark and Dr. Mamie Phipps Clark were a married couple who did this study in the 1940s. And the purpose of the study was to show the effects of segregation and racial discrimination on the self-perception of Black children aged 3 to 7. Now, when we think about the developmental stages, ages 3 to 7, prior to everyone hopping on the call, we were kind of talking about our children and, what they were into and how old they were. And my son right now is 8, almost 9. But when he was 3 to 7, I literally had on my track shoes. Thank goodness I was a runner because he was all over the place. He was into everything. And these were ages where we were really reinforcing positive reinforcements to him. We were telling him, you're great, you're amazing. He could draw a picture and I would look at it like, what the hell? And I would say, it's beautiful. Thank you. You're the best. You're like a little Picasso in training. We're pouring into our children. We're really, because we realize that these are very significant developmental ages. So when we go back to the 1940s and we're asking these children, ages 3 to 7, and it were both male and female, they were both boys and girls at the time. They were shown two identical dolls. The only difference between these dolls was the skin color. Everything was the same. And majority of the children gave the white doll positive attributes and the Black doll negative attributes. And these were just little dolls. They couldn't talk, they couldn't do anything. They were just dolls. And a big part of that is based upon what they were shown, what they were saying in the media, what the representation of Black looked like to them at that time. And I think this is important because it talks about the representation. If we go into a place and we don't see anything that looks like us or anything that we can relate to, for most of us, we may go another place. But for our clients, that might not be an option. That might not be as an accessible of a choice for them. So I think it's important that we understand how important the balancing of representation is. The implications for BIPoC mental health and eating disorders. It says here the doll test illustrates the psychological impact of systemic racism in media representation, which also reinforces body image issues in BIPoC communities. Key connections include internalized racism and body dissatisfaction, like the preference for white dolls. Media and cultural beauty standards are often idolized whiteness. BIPoC individuals may internalize a belief that their natural features or body types are inferior, contributing to low self-esteem, disordered eating patterns, and a desire to fit in by changing physical appearance with things such as skin bleaching and extreme dieting. During my years as a cheerleader, there was an internal struggle that I often had about making sure that I had the right look. I wanted to make sure that I had a look that would be received and validated by the NFL. In my own personal world, I thought I looked fine. In my family and friends, in my intimate setting, I thought that this was just the way that I looked. I'm a little bit of my mom, I'm a little bit of my dad, this is me. But in that particular world, there's a look. And I often struggled with, do I have the look? Can I be what they need me to be? There are certain things about me that I can't change. There are certain things that are just part of who I am because of my ethnic background, things like my hair and the texture of my hair, these types of things. And I was told, that I needed to look uniform. And by uniform, they mean the other girls on the team. Well, there were times when there were only maybe 4 to 6 minority women on a team of 30. So who do you think is going to have to make the biggest transition? The 20 something or the 4 or 6 of us? And so what that can do to someone is make you question, am I enough? And when we look at present day and we look at our clients and we look at the onset of social media and we look at filters and we look at airbrushing and we look at what is idolized and what is prioritized as beauty, it might not be as much as black and white anymore, but it's definitely thin. It is definitely thin. It is definitely a hair type. It is definitely a physical feature. And for a lot of our clients, they're not going to be able to check those boxes. And so we need to be able to understand that, and we need to understand the relevance of what that means in representation. Identity struggles. Just as the doll test revealed, BIPoC individuals may experience conflict between cultural identity and dominant norms, the exact thing that I was going through. This tension can exaggerate psychological distress and hinder recovery from eating disorders if not acknowledged in treatment. W.E.B. Du Bois talks about this as a double consciousness theory. And what he says in this is that when you have a client or you're working with someone that is not a part of the majority, they are prone to have more anxiety because they are internally conflicted between how to fit into the mainstream while also maintaining a loyalty to their own personal culture. And they feel as if they have to choose. And we never want our clients to feel as if they have to choose or eliminate something else from their life. We already know that they have been prone to eliminating particular foods. They're eliminating certain things because of the eating disorder. We do not want them to have to add another thing of elimination to that list. So that is why it's important to blend the two. The urgency for representation in culturally responsive care. Without diverse, affirming representation in therapeutic settings, BIPOC patients may relive the emotional harm depicted in the doll test. Culturally affirming care, including representation in clinicians, peer support groups, and educational material, is critical for recovery. When we think about our own practices and we think about our materials, if you work for a particular program, what do the models look like? Are we playing it safe? Are we putting up, a bunch of sunsets and, shadow people walking on the beach, or are we really being intentional in providing images that can relate to humans, that can relate to people? And I love to see the onset of just when I go to conferences and we're looking through materials of what that looks like for each program. And it's nothing more refreshing to be working with the client and you get them through the admissions process. I know there's some people on here that can relate to this. You get them through the admissions process, you get all their labs, you get everything approved, and they get to you and you're sitting there and you're ready to do the work. And one of the first things that they say is, I'm so happy to be here because this was one of the first places where I actually saw people on the website that look like me. I actually saw where there was information in Spanish. I actually saw where there was an LGBTQIA plus couple. There was somebody there that I could relate to. We know that this career in this field is about relationships and being relational. We all have I like to call it alphabet soup after our name, and we can break things down and we can rattle off theories and we can do all of that. But the beauty of it is our ability to connect. And I think that is what this is about. I think the doll test shows us and reveals that there is a huge disconnect. And now we have an opportunity to provide connection. The complex nature of eating disorders, we could go on and on about this, but it's important to mention that, eating disorders are serious conditions that affect mental and physical health, which can be life-threatening. Very rarely do eating disorders just show up as a solo act. It's usually a group, a quartet, a duet. It's something else that is happening with our clients, whether it be substance use, trauma, depression, anxiety, OCD. We know that very rarely is it just simply going to be an eating disorder. So eating disorders have the second highest mortality rate of any psychiatric illness. I think it's important to say that because eating disorders don't get a lot of shine and they're that dangerous. You hear more about depression, anxiety. You do not hear anything like that about eating disorders. And I've always wondered why that was, but the reality is that eating disorders have the highest mortality rate. Under the guidance of Dr. Wendy Oliver Pyatt, she is a very research focused psychiatrist and therapist. And we lean into understanding the numbers and looking at the relevance. And sometimes it just doesn't make sense that eating disorders are not as discussed as just as the others, but needless to say, that's why we have information in wonderful organizations like your IADIP chapter. The mortality rate 12 times higher than general population for females ages 15 to 24 with anorexia, and mortality rate for other specified feeding or eating disorder is 5%. Case conceptualization. So what I wanted to do now is just kind of go through a few examples of clients that represent BIPoC communities and discuss what we can do to treat these clients, how we can help these clients, and just think about ways that we can be inclusive, ways that we can be very intentional when something like this comes across our desk. So we'll start with Tasha. And Tasha is a 14-year-old African-American girl in a larger body who presents with disordered eating behaviors, including food restriction during the day and occasional binging in private. She expresses deep dissatisfaction with her body and frequently compels herself to thin Eurocentric beauty images she sees on social media. She reports feelings of isolation, sadness, and anxiety, especially around peers and during meal times. So let's just think about that for a little bit. So what we know is that she's 14. She's doing a little bit of binging and purging, and she's on social media like most 14-year-olds are, like most people are nowadays, right? She's on her social media and she's getting messages and influence through social media. Her parents are unaware of the seriousness of her symptoms and often dismiss her struggles, making comments like Black girls don't get eating disorders or you just need more discipline. They express frustration at her attitude and withdrawal, but do not recognize it as a sign of emotional distress, right? So Tasha is a very classic case. We have the family that comes in that is sometimes not on board and can sometimes be harmful with this type of situation. But we also know that because she's 14, we've got to incorporate the family. And as professionals, we know that eating disorders thrive in isolation. And what we do know is that Tasha is probably not reaching out to anyone. She's suffering in silence. And because of that, that is really intensifying her symptoms. So how can we help Tasha? We're going to look at the cultural and context considerations, right? Cultural stigma and misinformation. Tasha's family holds a common cultural misconception that eating disorders primarily affect white individuals. I think now the term is swag, skinny, white, affluent girls. Sometimes we hear that. This limits the emotional support and potentially delays the access to care. Body image, it says Tasha is navigating dual pressures, fitting into dominant, often white-centered beauty standards online, while also contending with family or community expectations that may not fully affirm or understand her experience. So we already see there's a lack of support there. And then the age and identity formation. As an adolescent, Tasha is in a vulnerable stage of developing her identity, self-worth, and autonomy, all of which are undermined by her internalized negative body image and lack of validation from her immediate environment. So let's think about what's going on when we're 14. When I was 14, I don't know if I was Miss Congeniality. I probably was extremely moody and probably got on my parents' nerves. But a very significant age. This is an age where you're coming into and people are asking you more than ever, like, what are you into? What do you like? What are your grades like? What's going on? So here we have to take all of this into consideration. Therapeutic approaches that may be helpful for Tasha. We can definitely do CBTE. Why? Because this is an evidence-based treatment for eating disorders, including binge eating and restrictive eating with adaptions for adolescents. Work with Tasha to identify and challenge disordered thoughts related to body image, weight, and food, help her monitor eating patterns, emotions, and triggers, and develop alternative coping strategies for her managing negative affect and low self-worth. Culturally responsive therapy. Why? Because Tasha's racial and cultural identity is central to her experience. Therapy must validate and explore these dynamics, acknowledge the specific pressures Tasha faces as a young Black girl in a body that is marginalized in multiple ways, explore messages that she's internalized from family, social media, and culture. And the key word is explore, right? I think it's important for us to make sure that when we're exploring and when we're asking, we're not necessarily coming from a space of, oh my God, that is so wrong. We have to be willing to listen and validate and go into these conversations with an open mind, just to say, well, here's another viewpoint. I understand what you've thought or what you have been, told or what you've been shown, but this is also another side of that. I think it's important to do that. We have to take into consideration that a lot of this information is going to be brand new and we cannot come in hot. We have to come in gentle. We have to come in patient. We have to come in open. Providing psychoeducation about how eating disorders impact all racial and ethnic groups. This goes back to if you're sitting in a family session, with Tasha and her family, and they come into the office and they're looking around, we want to make sure that we're not perpetuating any stereotype. We want to make sure that they can see people and they can see things that is relatable to them. Okay. Using affirming language and representations, like I said, role models, imagery, and counteracting societal biases. I think we're doing so much better in what we have in terms of variety, even from, kind of branding and marketing. There are several companies that have adapted using a more natural body and just using more real people to kind of market their products and, getting away from that very sterile, like you got to look like this. I think we're now seeing where this is for everybody. I love Dove. Dove is one that does an amazing job of just making sure they display a variety of bodies. And why wouldn't they? They have a company that's about body care and hair care, and they've just gone above and beyond to really showcase their brand as one that is inclusive. That just popped in my mind. I have no ties to Dove. Let me be very clear, but that just popped in my mind. Family-based therapy with psychoeducation. We have to involve the family when we're working with adolescents, especially if that's your sweet spot, and God bless you, that working with the families is not easy, and especially working with a family that is coming in with their own preconceived notions and not as open. This is where we use the psycho-ed. Educate Tasha's caregivers about the realities of eating disorders across racial lines, address parental misconceptions in a non-shaming way, and help parents understand their reactions and beliefs might be unintentionally invalidating. No parent wants to hear like, hey, you're screwing up your kid, right? But they may need to hear that, hey, some of the things that you've learned, no fault of your own, could be contributing in this way, right? And empower the family to provide structure and support without reinforcing shame. Emotion focused and compassion based interventions. Why shame, loneliness, and low self compassion are common in eating disorders. Use compassion focused imagery and journaling exercises to help Tasha build a gentler inner voice and validate her emotional experiences and teach her to regulate her emotions without using disordered behaviors. And then lastly, for her, incorporating media literacy. Okay. Again, right now, social media, all the social platforms are there and people are on them. And if we can mix in some of that positive imagery or provide, other options for her to look at, it would be helpful rather than just completely pulling social media all together. Let's try to meet Tasha where she is. I have seen so many times where clients are like, they just got to get off social media. Well, the likeliness of that is hard, especially coming from a program that is intentionally remote eating disorder care. We are a social media type of program. And so sometimes we have to be realistic and we have to be willing to just kind of meet our clients where they are and get into and say, well, share with me what are some of the pages that you're on and let me share with you some of the pages that I'm on. What are your interests? What do you like to do? You like to read? You like to journal? Oh, I know some really cool sites that you could get to that talk about that. So being willing to incorporate things that are not just eating disorder focused, but to just kind of grow the options and resources for our clients and encourage critical thinking about digital content and its impact on mental health. So as we think about Tasha, of course, like I said, there are more things that we could do to assist Tasha, but those are just some things that came to mind that I thought would be helpful. And I'm always open to hearing any of your ideas or suggestions. All right. Number two, Daniel. So let's meet Daniel. Daniel is a little more complicated, okay? Because Daniel is a 23-year-old Asian American male currently enrolled in medical school. He presents with symptoms of an eating disorder characterized by rigid food rules, obsessive calorie counting, excessive exercise, and periods of food restriction followed by emotional distress. He reports high levels of perfectionism, striving to be the ideal son and student, and often feels like he's failing if he does not meet unrealistic expectations. He experiences extreme pressure to honor his family's sacrifices and uphold cultural values around success, discipline, and emotional restraint. At the same time, he is internally torn, wanting to fit into more individualistic, emotionally open American cultural norms. To cope with this internal conflict and overwhelming pressure, Daniel has engaged in occasional non suicidal self injury, which he hides from his peers and family. So Daniel has a lot going on. So Daniel is one that I think we think about his age. He's an adult, so there's going to be some limitations around including support because he will have the ability to say yes, I want support, or no, I don't. And when we think about support, I think it's important to make sure that support can be whoever our clients need it to be at that time. It doesn't necessarily have to be a family member. It can be a neighbor. It can be a coworker. It can be anyone that they feel that would benefit from having this information and learning about what's going on with them. One of the things that we do it within, we're very intentional around giving our clients the opportunity to say, who would you like to include? Because when we open up the door and we say, hey, we're going to do family therapy, for some people, they're like, well, then I'm not going to do this program. So we need to say, who do you think would benefit? Who, and they'll say, I don't know, maybe my neighbor. Cool. We're good with that. Let's call the neighbor. Being able to kind of get out of these boxes and these traditional things, because for some of our clients, they may not have family of origin. That may not be an option. So we may need to look at just how we define family and make sure that that is communicated to our clients when they're coming in. So for Daniel, cultural and development considerations, the bicultural identity conflict, Daniel feels trapped between collectivist expectations and Western ideals of authenticity and self-expression. Going back to that double consciousness that W.E.B. Du Bois talked about, being able to do both and feeling the pressure of how do I lean into one more or less than the other. Perfectionism, we see this often with our clients. His drive to be perfect stems from cultural values, fear of failure, and identity-based anxiety. And, one of the things in the description was that he wants to maintain, a certain presentation for his family. He wants to honor that. And we have to understand what that means to him and his culture to want to honor his family. Mental health stigma, help seeking behavior may be impaired by shame or family attitudes that discourage emotional vulnerability. And I think we see this a lot in our male clients. There is still just a huge gap when we are getting males into treatment. And again, it's not that males don't have eating disorders. It's just where are they going? We have a gentleman, very kind gentleman that works for us, very knowledgeable, Joe Kelly, who does work strictly for male loved ones, strictly centered around male loved ones and what that looks like for male loved ones and those that are coming in to treatment. And masculinity norms. As a male with an eating disorder, Daniel also faces the added layer of stigma and invisibility around males with eating disorders. So how can we help Daniel enhance CBT for eating disorders? Why would we do that? Because it can target the perfectionism, the rigidity, and eating pathology in a structured, evidence-based way. If we know that Daniel is a med student, he probably is going to be intellectualizing things. So these types of therapies really help our clients to feel connected. We can't necessarily always say, stop trying to figure it all out. Stop trying to figure it all out. If this is how someone is wired and this is what they're doing, this is another way that we can show them and teach them at the same time. We can say, hey, Daniel, this is why I think this is good. There have been so many situations where I've worked with clients and they've said, I've never really understood why they were doing what they were doing. And there's an opportunity there, another opportunity to connect. Let's talk about why we're doing, what we're doing and why this can be impactful. Focus on Daniel's dysfunctional core beliefs around control, achievement, and self-worth, being contingent on performance. Identify his eating behaviors as maladaptive, coping strategies for deeper emotional and identity related stress, and introduce flexible eating, challenge distorted thoughts, and address the overvaluation of control. Schema therapy. Daniel's inner critic is harsh and unrelenting, often shaped by family and cultural expectations. How are our clients talking to themselves? A lot of times it's important to kind of check in on that and ask them, what is the communication like with yourself? A lot of times our clients will, kind of name their eating disorder, put a name on it, and we have to check in. And what does that conversation look like between the two of you right now? What is Ed saying? What is Ed not saying? Is Ed being quiet? What's going on there? Daniel's inner critic is harsh and unrelenting, often shaped by family and cultural expectations. Identify schemas related to unrelenting standards, defectiveness, shame, and emotional inhibition. Use imagery, rescripting, and limited reparenting techniques to challenge these deeply held beliefs and validate the adaptive origin of his perfectionism while helping him loosen its grip on his self-worth. Culturally adapted ACT to help Daniel build psychological flexibility while integrating bicultural identity. Focus on values clarification, separating what truly matters to him from internalized expectations. The use mindfulness-based strategies to accept difficult emotions without judgment, and then to help him create a life driven by intrinsic values rather than avoidance or compliance. And lastly, our last case study is Camila. So Camila is a 41-year-old Latina woman who presents with a history of disordered eating, categorized by restrictive intake and compulsive exercise. She expresses chronic dissatisfaction with her body and often seeks validation through social media and others' opinions. Camila reports frequent alcohol use, which she identifies as a coping mechanism to manage distress related to past sexual trauma perpetrated by a family member. As a result of this trauma and the associated shame, she tends to isolate from family members and struggles with intimacy and trust. Right? So Camila is another one that I think we see. Our clients come in again when we talk about the complexity of eating disorders and how they very rarely show up alone. This is a situation where the eating disorder is present with a little bit of substance use and trauma. So we looking at the cultural consideration for Camila as a Latina woman. Camila may face cultural stigmas related to mental health, sexual abuse, and substance use. Cultural values such as familismo, a core cultural value of family loyalty, might contribute to her isolation, especially if family cohesion is prioritized and the abuse has caused a rupture. So here's a reason why her culture could be keeping her quiet and keeping her in shame because of a core cultural belief. Her cultural background may also influence her understanding of body image, gender roles, and coping strategies. So, what do we need to take into consideration? The trauma history, the eating and body image concerns, and the substance use, and how all that plays a part. Camila having a significant trauma history by a family member, the trauma appears to be unresolved and contributes to these deep feelings of shame, worthlessness, and mistrust. all of which we know will really fuel the eating disorder. And if she is isolating and not talking to anyone about it and managing it on her own, this puts her at a greater propensity for even higher risk. Okay. Um, when she engages in restrictive eating and compulsive exercise, these behaviors often associated with attempts to try and regain the control or numb her emotional pain. The body dissatisfaction is persistent, possibly exaggerated by comparisons again to social media, trying to see how many likes we get, how many follows we get, or what people are saying, or just again looking at these very fictitious images of people on social media that again have been filtered, that have been airbrushed, that at this point could even be AI, not even real people, but really putting yourself in a very difficult predicament, almost unrealistic, to try and look like something that was generated from a computer screen. But these are some of the struggles, that our clients are dealing with. And then the substance use. Camila misuses alcohol to manage psychological distress, including symptoms of trauma, negative self-image, and this could represent a form of self-medication. The treatment recommendations, of course, trauma-informed therapy, looking at EMDR or trauma-focused CBT to process traumatic memories, focus on shame reduction and self-compassion. Eating disorder treatment is the obvious. Substance use support, making sure that there is a component where there is some education around that, and how that looks as it pertains to Camila's usage. And then, of course, CBT to challenge and restructure maladaptive beliefs, build emotion regulation, and distress tolerance skills. Cultural sensitivity, incorporate culturally relevant healing practices or community supports, normalize mental health struggles with her cultural context, and explore pathways to rebuild safe social connections, address family dynamics in therapy, if appropriate and safe. Again, meeting our clients where they are and keeping that cultural lens very much in the forefront. Understanding how we communicate, I think it's important that we take a look at communication styles, right? I think all of us have a communication style that we go to, and I think our clients have communication styles that they use. And I think it's important to understand what our communication styles are and what our clients' communication styles are, and especially those communication styles that they're having with themselves. Communication styles differ greatly among cultures, and recognizing these variations is essential for success cross-cultural interactions. Being aware of our own communication habits and paying attention to how we engage with others is really important. So when we think about a passive communication style, right, this communicator is typically avoidant, expressing opinions. They avoid that. Their feelings, they don't like to talk about anything because they do not want conflict. They're usually meek and mild mannered. They're hesitant when speaking, and they may say yes when they mean no. It is very difficult to communicate sometimes with someone who is so passive. And so we also have to be mindful of our communication style. And what I've learned about me is that unfortunately, sometimes my communication style will vary depending on who I'm communicating with. But needless to say, I think that just understanding where our clients fall and where we fall as communicators is very important. So we have the first one, which is the passive communication style. We get into the aggressive communicator. We all know somebody like this. This person expresses feelings and opinions in a way that violates the rights of others, right? This person sometimes can show up in group. As Tammy mentioned, I do our alumni programming, and every now and then we will get a client that kind of comes in aggressive, comes in hot, and we have to be willing to say, where is that coming from? Why are you using that style? How does that serve you? What does that serve you using this communication style? This loud, demanding, or overbearing interrupts, often uses criticism or blame, and the impact is that they get short-term results. And it damages relationships and trust. If I'm hiding out and I'm embarrassed and I'm shamed, the quickest way to get the spotlight off me is just to be loud, angry, and aggressive. And who wants to deal with somebody like that? It's my own protective wall. So I get to, kind of stay in my own little lane, and you don't get to bother me. So it's important to realize that there is something that is serving out of that. The passive aggressive communication style, this appears passive on the surface, but acts out in anger in subtle or indirect ways. That tricky, kind of communicator. Sarcasm is in the forefront. You don't know what you're going to get when you're working with this person. And we have to also understand if sometimes we can be a little sarcastic or cheeky when we're in sessions or with our clients, and that we don't give that energy back because it's sometimes we're human too, right? So this is where we have to check ourselves as clinicians and understand, like, do I have a tendency to be passive aggressive? If I do, I need to make sure that that's in check and that that doesn't kind of show its face when I'm working with others, especially if there is a disconnect or if there is a difference in culture. We want to make sure that we're not misunderstanding one another. Again, creates confusion, mistrust, and frustration. And then lastly, the assertive communicator, right? This is the one that we all would like to be. This is a person who's clearly able to express their thoughts and feelings in a respectful and confident way, direct but polite. They use good eye contact, listen actively while stating needs. And this is important, not that you all don't know how to communicate, but when we're having difficult conversations and we're having hard conversations, or we're entering into situations where we may not be as comfortable, it might not be our sweet spot, we want to make sure that we're aware of our communication style. Like I said before, we're all human. We all make mistakes. We all do things that we love, and we're better at some than other. But we have to make sure that when we're working with clients, especially clients that can come from, any background, but our BIPoC communities, we want to make sure that when we're having hard subject matter and we're having sensitive conversation, that we're leaning into a communication style that's going to be impactful and effective. And identifying microaggressions and bias, it's important because, like I said, we all have them. If we say we don't have them, then I would encourage you to, really rethink some things. I think as human beings, it's just part of who we are. Clinicians working with BIPoC clients must be acutely aware of microaggressions and implicit bias to provide equitable, respectful, and effective care. Here are several key considerations. Understanding and identifying microaggressions. Microaggressions are subtle, often unintentional comments or behaviors that express bias or discrimination. And I think the key word is subtle. And sometimes you may not be aware that things can come off offensive just because they're little small things, but they still can have a big impact and be hurtful. An example of a microaggression could be something along the lines of when you meet someone that doesn't look like you and they say they've traveled the world, and you say, "You have? Oh, yeah, you know, people travel, whatever it may be, right? That's just an example, but just, really paying attention to how those sometimes can show up. Examples about intelligence or socioeconomic status, assuming a BIPoC client is less educated or financially insecure, or being surprised when you find out that someone from a BIPoC community went to an Ivy League school or doing something, having this look of, oh my God, just being mindful of that. Colorblind statements, things like, I don't see color, invalidates the client's racial identity and lived experience. Exotic, okay. Exoticization or stereotyping, commenting on a client's cultural dress, accent, or food in a way that reinforces the otherness. An example of this is sometimes I wear my hair in braids, and it's just a normal hairstyle for me. I've gone into places and, oh my God, your hair. I'm just like, yep, my hair, it's braided, it's not a big deal. But putting that emphasis and just kind of really, the intention may be, I like it, it looks pretty, it's different. But for me, here it is, just me, and everybody's now looking at my hair. So these actions, can erode trust and re-traumatize clients sometimes, and just discourage that open communication. So just being aware of that. The reflect on implicit bias. These are unconscious attitudes or stereotypes that affect understanding, action, and decisions Clinical example, presuming by a BIPoC client exaggerates pain, where this is well documented in medical literature. We want to make sure that we believe our clients. If they come in and they're saying they're hurting about something, we never want to minimize that just because it's not something that you have experienced. We never want to minimize that. We want to make sure that we are listening and validating, believing that certain disorders are more typical in certain racial groups and thus missing or misdiagnosing, actions to take. How can we make sure that we're not leaning into microaggressions and bias, regularly engage in self-assessments, participate in implicit bias training, and use tools like the implicit association test to uncover hidden biases. I recommend everyone do it. I recommend everyone do it. You will be surprised at what the results are. And when I took my first test, it was very different than what I thought it was going to be. I thought it was going to be kind of like this multiple choice and, given some scenarios and you pick which one or which is the best, but it was nothing like that. It was very, very different. And it was set up in a way to really get your first response. And a lot of times they say the first response is your real response. So if you've not done an implicit association test, I suggest you do one. Foster cultural humility. Cultural humility involves a lifelong commitment to self-evaluation and redressing power imbalances. In our practices, we need to make sure we're asking open-ended questions about a client's cultural background, beliefs, and identity. Avoid assuming cultural norms. Everybody's experience is unique. Respect the client's definition of wellness, community, and healing, meaning if a client comes in and they have a certain diet or they have a certain, cultural activity that they, participate in, we want to make sure we don't say, oh, no, 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 you don't need to be doing that. We want to give them that space and we want to give an opportunity for us to learn and for us to understand. Validate lived experiences, why this is important. BIPoC clients may face systemic racism, intergenerational trauma, and daily discrimination. Believe clients when they talk about experiences of racism or discrimination. Avoid minimizing or rationalizing those experiences and provide space for these topics in therapeutic dialogue when appropriate. If someone comes to you and they say that this has been their experience, two things can be true. You may have not had that experience with that individual, but we definitely don't want to say they wouldn't do that. No, I think you misread. I don't think you read the room. No, 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 no. I think you're overreacting just because again, it's something that we haven't experienced. We want to make sure that we validate the lived experiences. And by validating, we're not saying it's right, it's wrong. We're at least saying in the moment, I hear you and I see you. And that's very, very important with our clients. Be accountable and repair ruptures. When mistakes happen, acknowledge the microaggression or braised behavior, apologize genuinely without defensiveness. And when we say without defensiveness, I'm sorry. Not, I'm sorry, I was having a bad day, I was rushing, it slipped. No, 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 just, I'm sorry. Commit to learning and doing better. Like for an example, if a clinician mispronounces a client's name repeatedly, they should acknowledge the mistake and ask for the correct pronunciation and make a concerted effort to get it right. Just fix it. If we make a mistake, we fix it. Create an inclusive environment, ensure office materials. We talked a little bit about this. Posters, magazines reflect diverse populations. Use intake forms that allow clients to self-identify their race, gender, and pronouns. Seek supervision or consultation with culturally competent professionals. If you have an intake form, it's okay to put a question on there to ask, like, how has your culture impacted your day-to-day or your relationships with food? That was one of the things that we did at Within when we were going through and creating our BIPoC space. We needed to ask the questions. We needed to at least get the conversation started. And we were able to get a lot of information just from that question. Some clients say it hasn't, some say it has. And so at least it's on there. There are so many times where the questions aren't even there. So if the questions are not there, then how will we know? And I think that goes back to broadening the scope of research and changing up the questions sometimes that we're asking. Where are we right now? Advancements and improvements. While there is still work to be done, there have been improvements to care for those in marginalized communities. How do we as clinicians sharpen our skills and take actionable steps towards leveling the playing field? One, training and education for providers. Diversify the conferences and workshops that you attend. If you're constantly going to the same conferences, open yourself up to doing something different. The BIPoC Eating Disorder Conference is taking place in July, July 16th through the 19th in Houston, Texas. I would highly recommend that you visit the website. It is a virtual and in-person conference. This is a conference that has traditionally been virtual since its inception, but this will be the first year that it will be in person. So we are looking forward to being there and learning and just being in community with other BIPoC providers and just learning. And we would love to have other clinicians there in the field. I think it's important to make sure that we are diversifying just the conferences and things we're doing, professional organization involvement, seek out organizations that prioritize a culturally competent care model that creates spaces for clinicians of color, challenge diagnostic norms, broadening the scope of research to include those who have been historically marginalized and underrepresented, and culturally grounded therapies, being willing to integrate some of the integration of Indigenous healing practices and spiritual framework, I think are, some pretty simple ways that we can begin to be more inclusive. Final thoughts. Just inclusive care is just not an ethical imperative. It is clinical excellence. By embracing diversity, respecting lived experiences, and addressing health disparities, we foster environments where all patients feel safe, heard, and truly cared for. Healing begins when equity leads care. Let us commit to delivering care that is not only evidence-based, but person-centered, culturally responsive, and universally accessible. Thank you.
Thank you, Jamie. Um, so great. I always have lots of questions in my mind, but what I was thinking is since we have a nice intimate group, is that maybe people can if everyone on their screen can see the reactions button at the bottom, you can just raise your hand for questions and we can just do it in that way instead of reading off questions. So I'm sure people have questions or comments or thoughts.
Or comments or anything. I'm open, and I know it was a lot. Liz, I
Liz.
think.
Yeah.
Hi. Thank you so much. This has been so incredibly helpful and engaging. And you kind of touched on this when you were talking about microaggressions and like the comment about your hair, for example. And I'm wondering if you could talk a little bit more about like white clinicians, especially like overcompensation as a microaggression and how that shows up like in eating disorder treatment, especially.
Yes, great question. I think it's a thin line, right? Because the intention is there, and that's why I wanted to continue to say that a lot of times it's unintentional. I think you just kind of go into it from a knowledge base, right? And if there's something you want to know, if there's something that you want to learn about, you go into it the same way that you go into everything else, right? If I'm one time out, this idea just popped in my head. When I was in college, I went on a date with this guy and he was like, "We're gonna go bowling." And I was like, "Okay, cool." Seemed very simple. Well, he showed up, he had his own shoes, his own ball, everything. I was like, "Oh my God. Like, we're not going bowling. Like, you're a bowler, right?" So he showed up like overcompensating for this date. Like, this was not that type of party. So I hear your question, and that popped in my mind. Just show up as you are. Just show up authentic as you are. I'm here to learn. This is something that's very new to me, and this is something that I want to learn more about. And I'm here, to kind of familiarize myself with some of the best practices. That's how you show up. You don't have to wear any t-shirts. You don't have to do anything. You just need to be open. And I think that is what gets lost. I think sometimes we feel like in order for them to know that I'm woke or that I'm an ally, that I need to, wear it on my sleeve. And you don't necessarily have to do it. It will be felt. It will be felt. Your genuineness will be felt. And I think it starts by going and taking those initiatives, like going to the BIPoC conference, right? Like, connecting with attending some of these talks and lectures. And it's sad sometimes because when we're doing these things, it's so much good work that's happening. But for whatever reasons, these conferences are not, well attended across the board. I don't know if it's a marketing thing, but just any opportunity that you can, Liz, to immerse yourself and meet people, just show up. I think that's the first step. You don't have to overcompensate. You just need to show up and let it be known that, hey, I'm Liz, I'm a provider, I'm here, and I'm here to learn.
So thank you so much.
Like we don't need you showing up in a bunch of kente cloth and we we don't need that. We just need you to be there sometimes and be present. You know what I mean? Just be present. I thought I saw a hand. Kate?
Hi, thank you so much. I appreciate the presentation. It's been awesome. And I have a question. I'm not really sure how to word it, but you just kind of answered it too. But I'll just say what I was thinking. So, like, as a white provider, and I think a lot of my cohort are like white providers, and I want to interact more with diversified providers because I think, like you said, like we're not asking the questions so often to people in minority groups. Um, and I know that I don't know. I was just wondering if you had any advice for me as a white person wanting to connect more with diversified providers and like spreading the awareness of eating disorders in all communities as a white person. And obviously that's not your job to educate me on, but like I'm wondering your thoughts.
No, I love the question. We're colleagues. Yes, if I have information, I'm happy to share. Kate, one of the things that, again, I'm in Atlanta, so we have a rich community of eating disorders and a variety of specialties, but just kind of do some digging in your area and see, if there are any HBCUs where you live, they have a counseling department, right? Connecting with those folks, right? We talk about colleges and all of that, but for whatever reason, HBCUs are a lot of times are not in these conversations. That's a way that you connect. As far as professional organizations, our IADEP chapter here in Atlanta is pretty diverse, and you can connect with other IADEP chapters and say, "Hey, have you guys ever done this, or do you know of any resources in this area?" The same way that we would go about finding out any other information. We would reach out to people. We would say, "Hey, do you know? Have you heard of?" That's the same way you do it for me, right? Again, this is my opinion with getting information on marginalized populations or BIPoC communities, just kind of asking around. And again, I cannot speak highly enough of the BIPoC Eating Dis Conference. It is virtual and it's in person. Dr. Whitney Trotter and Angela Goins are amazing. Angela is a dietitian. Whitney is a provider, also has a dietitian, but they have really put together just a plethora of resources for us to be able to pull from. So please, please, please visit that website and just kind of see what may interest you. But this is the first conference that has been dedicated to like BIPoC eating disorders. And again, they started this right after the pandemic, like I want to say in the 2022, 21 kind of deal. And it has just grown. And now they have sponsors and all of the, major treatment centers are exhibiting and will be there. And so just kind of being a part of that and being in that space, I think is a good start.
Thank you so much. I appreciate it. And I will be in Houston for the conference. I can't wait. Yeah, thank you.
Hey. Nobody else?
Well, if anyone has any other questions, we know how to reach Jamie. So, any other questions or comments or thoughts? As always, I always learn so much from you, Jamie. So, thank you so much for taking the time. This presentation was amazing. I love the case studies. I had the honor of being able to see your slides beforehand. And I wanted to know if Johanna or Elise needed to do anything to wrap up.
Uh,
Um,
oh, go ahead, Elise. You go.
I'll just chime in quickly. And first of all, thank you so much, Jamie, for your presentation. I can just feel your passion and it's so energizing. And so thank you so much for being here. I'm so sorry, I have a cold that I woke up with this morning. Um, but just quick note too for everyone to look out for the email following this presentation for the course evaluation. Lisa did post the sign-in sheet, but we'll send that as well in case anyone missed it. So that's all for the CEU stuff. And then yeah, go ahead, Johanna.
I was just gonna say exactly what you said. Jamie, thank you so much. This is like such an important topic, one that I know that, like we all have been excited to hear from you about and are ready to implement more of like what you talked about into our practice. So thank you. Yeah, and thank you everyone for attending. Very excited. And thank you to Within for lending you to us for this.
You. And and when it comes to like talks within, we do tons of them. That's another hat that I wear. I'm the person that kind of gets all of our presentations approved and ready. And so we have a few that we have coming up that if you visit our website and some of our social media platforms, you will see we have weight stigma awareness that will be coming up in the fall, which is always a really, really great conference. We have speakers from all over. I mean, it's just phenomenal. What happens with the weight stigma awareness. I don't know if you guys are familiar with Shavice Turner, but between Shavice Turner and Dr. Wendy Oliver Pyatt, they pull speakers from, kind of all over that have been, kind of like boots on the ground, like heavy into destigmatizing eating disorders and being inclusive. And then we have our Within Health Summit, which is something else that we do where we'll be offering up to 12 CEs, and it will be another opportunity to learn from some of our staff and community partners just about being inclusive and incorporating, mental health care in areas where there usually aren't, and just making ourselves accessible. So thank you for letting me share your stage and your platform. I really, really do appreciate it. And it means a lot to me to have your attention and this audience. So thank you so much.
Thank you. Thank you.